And this is the first fellow lecture of the year, I believe. So, Sammy, you were the lucky one to go first. So,
Uh,
without further ado, I'll let you go ahead and get started.
yeah, I'm sorry to put everyone through me being the first one, but my name is Sammy Dia. I am the pediatric HPM fellow here at Corwell and Holland DeVos. I know it's part of our curriculum, but thank you for everyone who's here and listening to this conversation. Our lecture today is on narrative medicine. Thank you to Kara at Trillium, who had a wonderful case presentation on a hospice patient in which narration played a big role in their healing. And then which led to this conversation, as well as an honor Dr. Mulder, who, when hearing that presentation, said somebody should do a lecture on narrative medicine, really just speaking to the holistic and humanistic care that he instilled in all of us. So, moving on, let's see. I have no personal or financial disclosures related to this topic. Objectives, these are just here for reference later, but we're really going to try to define, describe, identify, explore, and discuss various things in narrative medicine, how that relates to HPM as well. The contents as well are there again for reference, but as you see, I really want to start off with my story. I think that as we talk about narration in medicine, giving you my own narrative and how I somehow ended up in this spot, lucky enough to be able to speak to all of you and having that privilege of joining patients in their lives in the most sacred of times. How did I end up here? And a lot of it had to do with storytelling and healing, a lot of this narration in medicine. So this is my family. The picture to the left is my dad, my mom, and all their grandchildren. So my dad is Elias Dia. He immigrated to the U.S. from Lebanon, really for schooling. He came here to get furthering his education in engineering, worked for Chrysler for a while, traveled all over, works for GM now. My mom, Rajat Farhat, her whole family immigrated from Lebanon. None of them are there anymore. Immigrated here to America in the 1970s for more. And then there you see all my nieces and nephews. From the left to right, you have Isa, Noah, Elias after my dad, Olivia, and Elena. Next to the next image is me and all my brothers. And if you ask any first generation American or any immigrant, they say your parents told you can go into three different career fields, and that was healthcare, law, or engineering. And maybe we followed suit a little bit. So the first row are my two older brothers, Adam to the left, Ollie to the right. Both of them are emergency room nurses. Ollie at Sinai Grace in Detroit, Adam at Detroit Receiving in Detroit. My brother Fatty was pushed. He's the one next to me in the back row. He's the bald one. He's the youngest, but looks like the oldest most of the time. He was told he had to go into medicine as well. He was pushed into biology classes. He hated it. He actually ended up going into being a mechanic, and he loves what he does. So then that left me, and how I ended up here. My parents will say because they told me at a young age that I was going to be a heart surgeon. My brothers would tell you that it's because I had no friends and I could sit and study all day. Neither one of those are true. I think so at least. I think a lot of how I ended up here was actually my time at Wayne State in Detroit. So I went to Wayne State in Detroit for both undergraduate and eventually medical school. But when I went to Wayne State in Detroit, this is, I think, one of my favorite buildings in all of Detroit. It's Old Main. It's on the main campus of Detroit, and it's where a lot of our humanities classes are taught. And when I ended up going to Wayne State for undergrad, I initially was an engineering major, took courses in both Calc 2 and calc-based physics at the same time, and I said maybe this isn't for me, and really didn't know what I was doing. Medicine was always in the back of my mind, but I didn't know if that was the career path I would take. And then I took a course taught by Dr. Richard Raspa. Unfortunately, I lost all my images from like 2013 to 2017 because I never uploaded anything on my phone, and then I lost my phone. So this is the only image I could find of him. We'll quickly move on from it. Um, but he had a course called End of Life Stories. And it's, I think, a fascinating course to be taught in an undergraduate setting or just in general. I was always fascinated, I think, with end of life and dying. As my parents immigrated here from Lebanon, they brought their own cultural norms of death and dying and tried to find a way to mesh it with the Western world. And I don't think they ever meshed really well. We never talked about death or dying. We never talked about it being ill. When somebody became ill, like my grandparents, it was on the eldest child to help take care of them. And I watched my aunt give up her entire life to take care of my grandmother, who has since passed. But when with that relationship, I think it was their strain on it. I think I started to see them two grow apart. I saw my aunts and my mom and all of her siblings start to grow apart of that strain. And we really never talked about death and dying. So I was always fascinated and interested in it. So I took this course, and it was really to explore like the cultural and stories and constructs behind death and dying. And it was cross-disciplinary, looked at medicine, anthropology, humanities, and really it like highlighted the power of narrative to humanize dying and caregiving experiences. So we read a lot of books. We read the book that you see here that was written by Dr. Raspa, Dr. Gelfand, who is so anthropology, Dr. Briller, who's sociology, Dr. Meyer Shim, who is a doctorate of nursing, who wrote this about patient stories. We also read things like King Lear to examine death and dying. We watched a film, My Life, by Michael Keaton, where he's diagnosed with terminal cancer before his child is first born. We had a lot of just in-depth conversation. And one person who ended up coming as a guest lecturer is Dr. Michael Stellini, who some may know. He's a hospice and palliative medicine physician down in Detroit. He's either just now retired or is retiring this year. And he came and gave a lecture about death and dying in medicine, and I was became fascinated by it. And it really, this course pushed us to look at the stories at end of life that carry the ethical, cultural, and emotional weight, and really encouraged us to look at the stories that were
Right.
formed and how
Hi,
storytelling.
Cranky Pants. You okay?
Yeah.
Um, where was I? About just how storytelling led with death and dying. And I think one of the biggest impacts on me, Dr. Michael Slaney eventually became a mentor to me. But before that was a project we did, a part of this course that was done at the VA. This is the VA in Detroit, and it was the Veterans History Project. The Veterans History Project, what it was is we were taught by Dr. Raspa to try to learn to conduct an interview where we would go and meet with veterans at the VA at their time of illness. Often there were people who were alone and didn't have many people with them. And we would go and we would collect oral histories from them. And then their oral history would be sent to the Library of Congress. I was lucky enough to visit the Library of Congress. It's a beautiful building. I recommend a visit for everyone to visit. And that story is sent to the Library of Congress, and then it's sent there and is archived, and it is there to live on and preserve their legacy. Really what we learned, less of how to ask questions and conduct these interviews, but really how to witness and hold space, how to hold space and allow for another's truth to come to be. And it was fascinating to see how willing people were to open up when they truly felt seen, and you're just there to listen, to bear witness to their story. Um, their stories revealed themes of like identity, resilience, grief, meaning, and it really played a big impact on my life. And I was this kid in my young 20s, and just seeing that, sitting there and hearing their stories played such a big difference, and how being present could be therapeutic, just hearing someone's narrative. And it played a big impact on how I ended up here. And I actually then, because of this course, decided to pursue medicine and applied to medical school saying I want to do hospice and palliative medicine. Never thought I would be in pediatrics, and that's a story for another time, but knew I wanted to do hospice and palliative medicine with my interactions from this course, the impact of the Veterans History Project, and the impact of Dr. Stellini and Dr. Raspa. So that's my quick little story about how I came to be here and speaking with all of you. And at that time, storytelling and healing was this fascinating concept to me. It was something so different, but it's been around forever. And I thought it'd be interesting to talk about the history of storytelling and healing, or healing from storytelling. And what I learned is, as I was taking a deep dive into the history of storytelling and healing, is I truly could have picked any time from the evolution of Homo sapien to now on where we could have talked about any place in this earth, any time in this earth that there is storytelling and healing. So I really just picked some random ones, and I'll explain my reason why, but I thought that were a big impact on things to talk about. And throughout history, again, from beginning of human to now, oral storytelling was the main vehicle for transmitting any form of history or knowledge, not just medical knowledge, of course, but any knowledge in general. We did it through story and through history and speech. Often when we did it for healing or for medical knowledge, the stories that were used explained origins of illness, whether it was through spirits, curses, imbalances. Spoke of rituals or remedies that were used to help people heal, really to restore that social and spiritual harmony, that imbalance that happened when one was ill. The stories explained the values and social order of the community. Storytelling really became a form of cultural continuity. That healing wasn't just that physical, but that spiritual, emotional, and communal healing. A lot of that total pain we talk about now. And that healing was rooted in narrative long before it was rooted in science. There's when looking online, there's this ancient proverb that you see all over the place. It's not tied back to one person or one people, but it's if you listen to the story, the cure will reveal itself. And as you go through history, you could even see this in all indigenous peoples, like the indigenous peoples of the Americas, in Africa, the Aboriginals. All these indigenous peoples and tribes had healing practices that were stemmed in storytelling. Illness, as they saw, similar to ancient history, that illness is often seen as a disruption of harmony, that loss of balance, that loss of harmony, and that stories help realign individuals back to their community, their ancestors, their nature, and help reground them. This is often done through healing ceremonies, and those ceremonies include storytelling, but songs, myths, chants, etc. They're often led by a shaman or medicine person of sorts, and where that person is there to listen to the patient's life story. And as they listen to that life story, it's a diagnostic tool to find out how they can help bring them back. And sometimes that story itself is therapeutic. It's part of that ritual or journey back to the imbalance and harmony. The picture to the right is of my partner and I, Anara. We were blessed enough to visit the Southwest and take a nice road trip to the Southwest and meet a lot of, we visited the Navajo Nation and spent a lot of time there, met a lot of people um, of a Navajo ancestry, and they shared with us so many different stories. And one thing we learned about was of the night chant. And the night chant is a healing ceremony. It's a 9-night ceremony. It happens in the wintertime. It dates back to thousands of years ago, BC, in which it was first performed in the Canyon de Chelly, and that's the area of eastern Arizona now. But this night chant was this idea of where songs, prayers, sand paintings were done to help people heal. In the Navajo culture and the religious practices, it really emphasizes this connection of all living things and non-living things. And if we ever needed a time in history to embrace that idea, it's now that we are all connected as living or non-living things, and really how to bring those two back together as they are not separated and help people heal through storytelling, song, prayer, and sand paintings. Next, I wanted to talk about like ancient Greek times, because all of us sitting here and listening into this conversation at one point have said the Hippocratic Oath. And during this time of Hippocrates, there was this transition to case stories in which observation of patient experience, symptoms, and outcomes are really important in their in their overall totality of their life and not just healing. And there's texts that show this shift towards clinical storytelling with the beginnings of evidence-based thinking. There's this theory of amnesis. Amnesis is a part of Platonic philosophy and Socrates, where they talk about the soul itself being immortal. So amnesis it comes from Greek for the word recollection. But what it stands for is that the soul is immortal. It is repeatedly incarnated. That once one dies, the soul is transferred to another person. But the knowledge that you have is lost through the trauma of birth. And that as you continue through life from birth, everything you learn is something that you once knew. And they use this theory to explain things such as learning geometry. There's a story of Socrates in which someone that he met didn't know the answer to a geometry question. And as he walks him through it and the child learns it, he says, that's your opening back up of your previous knowledge. But it helped with going back for people of illness, of walking back their story to figure out what was happening and what has changed. And it became the starting point of diagnosis in which that story mattered. And again, it continued through philosophers. We said Socrates, Plato, Aristotle, where there was that connection between soul, suffering, and storytelling. I think, given my background, I had to talk about Middle Eastern Islamic traditions, but and So during the golden age of Islam of to the 8th to 13th century, there was this preservation of those Greek teachings, and really emphasized humoral theory. Humoral theory being that we are of four natures: blood, phlegm, yellow bile, black bile, which correlate with the elements of earth, air, fire, and water. And once something is out of balance, it, what happens is, or once one is ill, there's an imbalance of your humoral system, and that they have to find, as a physician's job, to diagnose which humoral um, part is out of balance and which chemical system regulating your body is out of balance. And your humoral system is heavily dependent on one's lifestyle or temperament. So a physician would try to figure out what is out of balance and who you are as a person, the lifestyle you lived, your own temperament played a big role in why it was out of balance. So it was truly learning one's story, learning their story, and that became a diagnosis to help them heal. During that time, physicians and philosophers like Abu Ali ibn Sina or Avicenna, known in the West, used case histories and believed firmly in that doctor-patient relationship, and that relationship is central to healing. He wrote many books, one of the books on the right being The Canon of Medicine in the 11th century. And it remained the medical authority for centuries. Up until about the 18th century, this canon of medicine was heavily used and practiced. And there's quotes in it that show that effective care requires seeing the person behind the illness. The first quote: "The physician must not treat the disease, but the patient who is suffering from it." And then other quotes of showing the importance of understanding the circumstances of illness, not just the symptoms, in which he says, "Examine the conditions of the patient, his habits, his environment, and the course of his life. These two are among the signs that tell the story of the disease." So much more of that effective care, meaning seeing behind more of who the person really is, seeing behind the symptoms, and learning more to help someone heal. Um, and as I said, that I could have picked any time in history, any area of the world, and given a story about healing coming from storytelling and narrative. Um, but so I think what's important is to really just talk about the themes across those traditions. As we could have picked anywhere, I think the big things that stand out is that illness is not just a disruption of the body, but a disruption of the story. As we lose the narrative, as we lose a patient's story, that's where, or as they lose their own story, that's where illness starts to arise. Healing requires reintegration into a personal or communal narrative, and that the healer is a storyteller, not just a technician, not just there to identify which humorous is out of, or humoral substance is out of balance, but really to hear their whole story to help them move along. Now, as we go through of me learning narrative, which what got me here and into medicine, the themes of storytelling and healing throughout um, millennia. How am I here now giving a lecture on narrative medicine and narration in medicine? I think there comes a time in history where we start to lose the narrative, where we start this descent away from narration into more objective values. And I think this happens around that same time of the 17th and 19th century, where I said those like the teachings of the canon of medicine were starting to be lost. And what really happens is you see this rise of the scientific model and a shift of medicine to align with the Enlightenment ideals of rationalism and empiric observation. The image to the right is one there I think we saw really early on in our HPM fellowship in one of our lectures. It's one that I used just a couple weeks ago to give a lecture to the pediatric residents about acute pain and somatic pain. And it's René Descartes' theory of pain. And René Descartes is French philosopher and scientist in the 1700s who really talked about, um, when he talked about the theory of pain, he really talked about this dualism, this separation of the physical body from thoughts, feelings, and the soul. And we spoke about a little bit earlier about this separation of the body and the soul, but where this idea comes from really comes from like the teachings of Galileo during that time, in which Galileo thought, according to the laws of the universe, that anything can be simplified into mechanistic property, and the only thing that could not was the soul. So similarly to that, Rene Descartes thought, pain can be simplified down to a mechanism of mechanistic properties where if I put my foot in fire, there is a pathway from my foot to my brain that says I'm in pain, and that we can find that pathway, sever that pain pathway, and you'll be pain free. What they didn't know is about our, ascending pain pathway amplifications, our descending modifiers. But this idea that things can be simplified down, really focusing on the idea that this body of ours is a machine. And then during this time, we also have the emergence of clinical pathology. The other person to the right is Javier Bichat. He's the buccal fat pad is actually named after him, the Bichat fat pad, in which he really thought that we need to shift the attention from patient stories to observable lesions. So he worked basically with autopsies. He would look at bodies post-mortem, and that he found that various organs were different and had different types of diseases. This was before his knowledge of a cell. He wouldn't use a microscope, but he was able to find like 21 different tissues and notice that these tissues and these organs had observable lesions, and that this is what led to disease and this is what led to death. So really, this shift from this your whole story to the body as a machine, let's find your observable lesion and let's start to target it. And then this leads to the formalization of medical training in the 19th century. And I think this is just a quote that I read that I really enjoyed that I wanted to add on here is that as medicine professionalized, the story gave way to the system. We start to lose the story in way of diagnosis and treatment. And I think one of the big parts in history that stood out to me of where we truly lose and start deep diving away and free falling away from the narrative is in the 20th century with the emergence of the biomedical model. Not to blame Abraham Flexner for all things, but Abraham Flexner was an American educator who who overviewed a medical education system in America, in the United States and Canada. And he came out with the Flexner Report in 1910. And what he advocated for was for science-based standardization of medical education, emphasizing biomedical research, laboratory science, and clinical rigor. And when you hear that, that sounds amazing. That sounds like what we need now. We need more than ever science-based, evidence-based medicine and education. So it did have positive impacts. There was this, like, as I was reading through critiques throughout time of what people thought of the Flexner Report, there was this elevation of medical education and standards. It promoted professionalism of medicine. Some people thought this was a benefit that it eliminated many unaccredited low quality schools. I put a question mark because at the same time, he undermined alternative forms of medicine. He undermined homeopathic medicine, osteopathic medicine, botanical therapies. So I think that was both, there's a balance there. But there was this unintended consequence of shifting to this biomedical model. It truly de-emphasized humanities, philosophy, ethics, the patient's full story. It prioritized diagnostic accuracy over patient stories of really the patient here becomes a case, not a person. The patient becomes a case and not a person. And then medicine shifted from this relational art to this technical science. Here I am to heal what is wrong by finding the scientific cause of it and not listening to you as a person. So then we were talking before this about, thousands of years in between, hundreds of years in between. I think people quickly caught on that we are losing the narrative quite quickly because in 1910, Flexner Report comes out 40 years later, there are big shifts back towards personalized care. Very first lecture of HPM, we learned about Cicely Saunders, who reintroduced that concept of total pain narrative medicine in palliative and hospice care. But there are big movements even before Cicely Saunders in the world of bioethics, psychiatry, sociology that really questioned that depersonalized care. Michael and Balint formed the Balint groups, and they're the image on the right. So Michael Balint was a Hungarian psychoanalyst who started off really with a big focus on marital problems. And I think the closest thing to a marital relationship and marital problems is the doctor-patient relationship. So they shifted and started focusing him, a group of social workers, psychologists, psychoanalysts, really focusing on the relationship between patients and physicians. And they really hoped that medical physicians would get together, discuss their patients, and discuss really the psychodynamic factors in a relationship to their patients. He was really upset that physicians would often, like go to tablets to help treat anxiety and depression and unhappiness, and would really tell, after seeing their patients, would come to these conclusions that nothing was wrong with them without actively looking into their full story. And he really wanted to push that. So they created these balance groups where physicians or general practitioners, groups of 6 to 10, would get together and talk about their patients in more detail. It also had the emergence from George Engel in 1977 of the biopsychosocial model, what we still learn today, that shift away from the biomedical model, where we're really bringing this narrative back in. And then we also have, the rise of patient advocacy, autonomy, and challenging of paternalistic medicine. You could find this. We talked about Eric Cassell last week and Arthur Kleinman, who were both Eric Cassell, American physician bioethicist, Arthur Kleinman, medical anthropologist. But their big focus was shifting back to the idea that the patient is the storyteller, or that the idea of the patient as a storyteller. So then I think this shifts back to you have people who are now pushing to return us back to this the biopsychosocial model and bringing back the narrative. Again, how are we still here talking about this? And I think this now talks from my story before to our story being all of us now in medicine. Um, the image on the left is me and my lab group, my anatomy lab group at Wayne State. We are gray 17. There are, I think, 50 to 60 lab groups at Wayne State, as we had 300 plus medical students every year. And Wayne State try to do a really good job. They had a valiant effort in making us, or try to help us focus that the bodies that we were working on, the cadavers that we were caring for, were actually patients. They were real people, as they were. We had the class was actually called Our First Patient, and we learned all about them. And we did things like humanistic writing and reflection assignments about how do we preserve humanism in our anatomy classes and our anatomy experience. And I think at first we did. I remember seeing our first patient's hand for the first time. And that's when I really when I saw the fingerprints for the first time, I'm like, these are inherently human and unique to this person. They are a person, and what a privilege it is to be here. And I think that was quickly lost. By the next week, we're all bouncing from lab group to lab group, cadaver to cadaver, looking who dissected the best brachial artery, not only to see it, but then to see which cadaver they're going to use on our practical that they're going to tag. And we quickly lost that humanistic and that story in medicine. The picture on the right is the graduating pediatric residency class of 2024. Um, and I think throughout medical residency, we start to learn how to create diagnostic stories more than we learn patient stories. I remember, and what we start to focus on is really recognizing symptoms and treating patients, and often their story put on the back burner. I remember early on in my residency career, we had a patient who came in who had rapid breathing while awake. While they're awake, they had rapid shallow breathing, really tachypnic. But when they went to sleep, their breathing was normal. They were no longer tachypnic. I went to the computer, started looking things up, went back to see the patient. I saw her hand was clenched, and I was like, oh my gosh, I think she has Rett syndrome. And we get genetics involved, and she has Rett syndrome. And I was so excited. I was like, I noticed that. I saw that pattern, and my recognition was there, and I was able to look it up, and they have Rett syndrome. And I was so excited I diagnosed it. And at the same time, I lost the plot. At the same time as I'm celebrating a diagnosis, that diagnosis was one that was traumatic, life-changing for this family. It was devastating. And that never came to my mind, maybe until way after the story, after discharge, that wow, I was really out of touch at that moment. I was out of touch with the humanistic side of medicine again. I was so focused on these diagnostic stories, being able to diagnose and treat, and at the same time didn't put into play the story of the family, the story of the patient. And I think what happens is in the 21st century now, we have the P's that pull us away from medicine, you know, productivity and performance. I was at my GP the other day, and as they're trying to reschedule me, I saw she truly had she had appointments booked every 10 to 15 minutes. And I saw like 40 something patients on their list. And I said, I'm, we're almost over a half hour, 35 minutes into this lecture, and I'm still telling you parts of my story. And they have appointments 10 to 15 minutes. platforms and paperwork. Um, our EMR systems only allow for so much, and we have to do so much documentation, and we're so worried about documentation. Patterns, protocols, and procedures. The patient no longer becomes, Sarah, Bob, or Joe. They become, what diagnosis do they have? What algorithm am I going to follow on up to date for their treatment? What procedures do we have to follow? What pattern recognition am I seeing? There's things like the profits of the hospital that we're concerned about, paternalism and power, perfectionism and presentation. The presentation part is I remember a time where I was a senior part of the team, and we had one of my colleagues would come back for morning rounds or doing table rounds, and they're sharing a story about the patient. And let's say we'll call her Lucy, and then she's talking about Lucy and says, Lucy loves her popsicles, but they have to be red popsicles. And when she said that, the attending was like, hurry this up, stop wasting our time. Don't tell us that. We don't need to hear at morning rounds, table rounds about Lucy's red popsicles. And at the time I agreed. I said, we have a busy list, we have to go. And how silly I was, how important that information is to knowing Lucy and helping to treat Lucy and her family. Especially something so detailed, something so specific, something so important to them. For her to have learned that about Lucy, it meant something, it mattered. And again, we lose that in this performance, productivity, presentation type of way. And I think where medicine really gets back to the narrative as well is the rebirth of narration and this wonderful physician, Dr. Rita Sharon. Dr. Rita Sharon is an internal medicine physician, and she has a PhD in English and literature. She has a wonderful TED Talk titled Honoring the Stories of the Illness, which I recommend everyone to read or listen to. Sorry. And it's about 15, 18 minutes or so, and it's wonderful. And she talks about how she was always a lifelong reader, had a love for literature, and noticed that literature, the connection of literature and medicine is not new. And we just talked about, right, for millennia, that storytelling and healing was always there. And she noticed that literature and medicine wasn't new. And she found that um, when she was practicing as a internist, that reflecting on the emotional and relational gaps that she saw in her clinical care, she became more and more interested in the narrative aspects of the patient experience, how stories affect diagnosis, empathy, and healing. In her TED Talk, she talks about how she understood that her job, like when a patient came to see her, that she was paid, not actually paid by the patients, but paid to give them her full attention. But not only her full attention in words, but in silence, in facial expression, in body expression, and that was their job and that her job. So she really wanted to tie back narration in medicine. So she went back to get her PhD, and there are some quotes here that she shared about why she did so. But really, she wanted to study what doctors do when they read, write, and listen. And she found that there are literary tools of narrative theory that could help teach us more in depth how to care for patients, both with justice and respect. So she merged the two, and she was the founder of the first narrative medicine as the entire narrative medicine field and the first program at Columbia in 2000. And she spoke a lot about narrative medicine, reclaims the idea that stories are central to diagnosis, healing, connection, and meaning. She says the physician's task is not just to diagnose and to treat, but to bear witness to the story of illness and to honor it. So, what is narrative medicine? Like, as that young kid in my 20s sitting there in the VA hearing these stories, was I practicing narrative medicine? No, absolutely not. I was witnessing storytelling leading to healing. I was learning how to bear witness to stories, how to be there without trying to cure. But I wasn't practicing narrative medicine. The practice of narrative medicine is a practice of attention and affiliation. Narrative medicine is clinical practice fortified by the knowledge of what to do with stories. So not only to hear the stories, but what to do with them. And Dr. Sharon talks about narrative competency. And to have narrative competency, it's the ability to recognize. So recognize that a story is being told. How often do we have patients that we talk about of they love to, they're chatters. They love to chat. They'll say a lot of words. But a lot of those times it's being able to recognize what part of that is a story being told, a story that we should absorb, interpret, help be moved by ourselves, be moved by the stories of illness, and to help patients use those stories of illness to help them heal. It promotes deep listening, empathy, and therapeutic alliance, and really engages the three movements of attention, representation, and affiliation. She says that the care of the sick unfolds in stories. So I think through that, she hopes, and we all hope, that the new kind of clinician is born again, or we rebirthed of where we bring back this holistic humanistic care, and encourages, again, that whole person care, reflective practice, training in literature, writing, ethics, recognizing both patient's narrative and the clinician's own narrative. Again, so narrative medicine, a lot of what we do in HPM as well is has a big influence, like has a lot of narrative medicine influence, but things that we can maybe and like give a little bit more focus to or improve on is like the reflective practices, training in that literature and writing, learning more of that their narrative, our own narrative, and how to help bring the two together. And as narrative medicine offers a model of empathy, trust, and communion. I think as we talk about Dr. Sharon, I think as a pediatrician, I have to talk about Dr. Rachel Fleischman as well, who is a neonatologist in Philadelphia, but she also is a narrative medicine advocate. She hasn't completed, um, I don't think she went through the narrative medicine fellowship, but she's a NICU provider who had an undergraduate concentration in creative writing. And I think it's fascinating to see the people who are narrative medicine champions really have this love of storytelling, literature, of the arts, and really blend it with their scientific rigor. She also has a wonderful TED Talk in 2017, Can Medical Storytelling Save Lives? And she sees that medical training is an apprenticeship, that we learn so much about medicine, about who we're trained from and who they were trained from. And we continue on down that path and sharing those habits. And one where those can be helpful, but they can also corrode our thinking. When speaking as a NICU provider, she talks a lot about death and dying is a part of doctoring. She says that she approaches the injustice of a child dying with her personal mission to give families my most dignified and compassionate self, to avoid layering miscommunication on top of tragedy, and to offer them your best self. Really talking about how to be present and how to be there in these times of, again, tragedy and devastation. Again, with the injustice of a child dying, how does she write that narrative of their story, or how does she listen to the narrative that the family's writing, write her own narrative, and combine the two? And she often does this. She says, you can do this by using the language of a civilian with the knowledge of a physician. So some things that she brought back to her hospital in Philadelphia was heavily influenced narrative medicine practices, things like reflective writing, humanity seminars, reading and reading patient and parental stories, storytelling events. How often do we have a storytelling event where we create space and vulnerability, spaces for vulnerability and resilience of the team members themselves? Mindful narration of clinical cases. The idea is what we do is heavy, and we bear witness to a lot of stories. And sometimes we need to bear witness to our own emotion as well. There's that silent weight of what we do, and holding space for ourselves is what narrative medicine is as well. It's not just listening to the stories of our patients, but listening to our own stories and reflecting on our own experiences and how that influences the care we're providing to patients, but also how that influences how we show up for our patients, how it allows us to practice our narrative competencies to be able to then be present, focus on the stories, identify the stories, and help guide patients through. And what throughout literature, what we found is bring back these narrative medicine practices from reflective writing to mindful narration of clinical cases. It actually mitigates burnout, strengthens team cohesion, humanizes care in general, and also in high acuity settings where we often lose humanistic care the most, and restores meaning and moral clarity in really difficult cases. So going through it is a lot of what Dr. Fleischman brought back to her hospital, what we can do in HPM, right? What they do is they help, some of the practices they do there are recognizing the story beyond the patient, that babies are not just their diagnoses. One, we say this a lot in pediatrics, that your child is more than the sum of their parts. Your child is more than their diagnosis of congestive heart failure. They are Lucy, they are Ben. And we can do that here in HPM, right? Every patient has a life beyond their disease. Incorporating family narratives into a care plan. We asked they over there, and I think we all should ask families to share who their baby is beyond their medical information. Here in HPM, during our goals of care discussion and family meetings, we can intentionally invite life stories. storytelling to humanize handoffs and rounds. I think we do a good job at this, and we can continue to do so and expand on it. Where when we're doing handouts and IDTs, that we include narrative pearls about patient alongside clinical updates, about Lucy's favoritism of red popsicles and only red popsicles. Teaching narrative competency early. I think we can do this for even our residents who round on our services, but for us, maybe considering adding reflective writing and story analysis to what we practice, valuing patient and family authorship. And we can do that the same here of giving patients and families rooms to narrate their own experiences. I put this slide again just for reference. We're not going to go through it in detail, but that narrative medicine and HPM share a deep kinship. They both center the person, honor stories, and seek to relieve suffering. And narrative medicine isn't always about action. Sometimes it's simply about listening, holding not only patient stories, but our own stories. And those are some things that we can bring back into HPM. So with I want to leave some time for questions, so I'm going to move on a little bit quickly, but how do we integrate then narrative practices into systems of care? And I think we could do that through research and QI. This is a slide, quick comments on pediatric HPM. This was a slide from the National Hospice Palliative Care Organization, sorry, NHPCO. They publish it every year, but just showing that in our pediatric population, unlike our adult population, often less of our patients are actually hematology oncology patients. About 30 to 40% are often hemonc, where the other 60 to 70% are genetic, neurodegenerative, neuromuscular, cardiovascular, pulmonary, um, perinatal, metabolic, etc. And often it's not just one of these things. It's often multiple of those things. It's often, genetic, pulmonary, and cardiovascular. It's often perinatal, GI, neuromuscular, neurologic. It's often this combination of what we end up calling our kids of children of medical complexity. And as you go through that NHPCO handbook, these are the patients that they share images of. And not to say like these are very beautiful children. They may have problems and they may have diagnoses, they may have illnesses that we follow in HPM, but often the patients we see are those children of medical complexity that are heavily dependent on technology, needing things like not only G tubes, but trach vent dependent, have neurologic severity and neurologic devastation. These are often the patients we see. And these are two images from HDVCH's social media page. And what's fascinating is these two images are two of patients who are familiar with the HPM team. But these images are 3 years apart. And these are the only two patients of ours that represent a common population of ours of children of medical complexity with severe neurologic impairment that I can find on any social media page. I went back, so this was one of the images is from 2025, the other one from 2022. I went back to 2019, I couldn't find anything. And then I just stopped looking. I was like, how far back do I got to go? I think I made my point where the patients we care for aren't really imaged or aren't really put up into um, social media. They aren't really televised. They're not the patients who are often put into these pamphlets, but they're the patients we care for. So how do we learn more about them? How do we find out our biases? And there was an amazing presentation and research that was done out of Seattle Children's that was presented this year, AHPM actually, that talked a lot about photo narration in children with severe neurologic impairment in the PICU. And then in 2025 is the one under it was showing more of that impact of it. So both of these are amazing articles, but what they did is to describe these patients more. When they come into the hospital, when they come ill into the PICU, they're often sedated, intubated, not at their baseline. And often our biases show. We go into those, providers will go into those rooms and be like, I remember as a resident, I would go in and be like, what is the goal here? What are the parents hoping for? Why are we doing this to this patient? Are they suffering? And asking these questions without truly first learning their own narrative, the narrative of the family, the narrative of the patient, and who they are. So they created this project of photo narratives, and it's a tool for that they created. This is what it looks like. There's questions to help prompt them to find photos, but they find 3 photos that best represent their child, and they're posted on the door of the PICU. So as a provider, any caregiver, whether it's PT, OT, SLP, dietitian, anyone walking, any consultant, anyone walking into that room sees three pictures of the child that the family chose to pick. And at HPM, there was a family there of one of the patients who came to show us their photo narrative paper and explained it all to us. And it was a patient of medical complexity, a young little girl, who the first picture of her was her standing in her AFOs, pushing and holding onto her wheelchair with all of her technology connected, but standing and holding onto her wheelchair. And the mother was like, I picked this photo because my child is ambulatory. Walking is super important to them. So once you come in and see her and if she's sedated, intubated, stuck in bed, that's not her. What we're fighting for is to get back to her walking, to her doing the things that she enjoys. The next picture she picked was her in her bedazzled bright pink wheelchair. I think they're either at a park or a zoo. And these are the things that bring her joy, being outside, going through the zoo. That brings her happiness, not being stuck in the hospital. That's what we're fighting for. This is who I always use Lucy. This is who Lucy is outside of this hospital. And then the third picture was a selfie of mom, dad, and Lucy. And when you see a selfie, you're like, oh yeah, family. That's cute. That's adorable. But no, what that picture meant to this mom, and she shared it with us, was that this is all we have. This is our world. Us three, all we have is each other. And when one of us are feeling down, we're all feeling down. When one of us is sick, we're all sick. This is our family unit. This is all we have. And just there, those three photos before walking into the room, you've learned so much about a patient and their narrative story. You learn so much more about them. So what we're hoping is here at HTVCH to integrate this into hopefully our PICU and maybe elsewhere. I would I would have to mention Dr. Hemker, who has always said that with our patients, when we look at our epic photo, we have just a photo snapshot of them in time. And often that photo is one of which is a selfie from like the lobby and it doesn't say share any story. His hope was always to have like almost like a photo album or videos of patients and maybe a biography that the family is writing to truly learn more about our patients of medical complexity. And I think we're trying to move forward with that here at HDVCH. And I would love so I want to leave some time. Love to hear about any other protocols people are doing at their own hospital system for photo narration or for other types of narration themselves. But what they did with this project is once they implemented that, what they noticed is prior to the implementation of photo narration in that paper, themes that were discussed through patients and clinicians, those interviews. So they interviewed parents and clinicians prior and then after. And what they noticed is the biggest themes were that clinicians have limited perspectives and multiple assumptions about perspectives on who their child was, and then assumptions on who their child was. And then after the photo narrative project and putting up the poster, the themes that stuck out were it helped elicit information to diminish that disability-based biases. Physicians, caretakers, and so they didn't only ask physicians, but they asked social workers, therapists, etc., any caregiver who walked in or caretaker who walked into that room, and their disability biases started to diminish. That they said, I now understand what this family is fighting for. Before, where I'd question why are we doing this to this child? Where are we trying to get to? I had no idea that this is who they were outside of the hospital. So it really helped enhance the understanding of a child's baseline health, where a lot of our children with medical complexity who are nonverbal, the noises they're making, a lot of the times we assume are normal. But learning the family story, learning the patient story, learning that narrative, that now that vocalization they're making is as, oh, actually, that's a sign of pain for them. That's not a normal vocalization. It's it's wild what happens when you truly take time to understand and learn your patient. They saw that the communication of the richness of the child and their quality of life and the relationships all improved, and it really catalyzed humanistic care. So we really hope to bring this into HDVCH. Some other examples of just applications of narrative medicine into HPM and what I was reading, and these are just some that in my like lit review that I was finding, but things like My Baby Is or All About Me boards, really talking and describing who the patient is, reflection rounds, those are more for us, like a weekly or monthly time for staff to share emotional experiences, legacy letters and projects, photo integration and narration, dignity therapy, life review conversations. I wish you knew exercises. I remember a patient in my adult oncology clinic who said, I got chemotherapy and I had significant neuropathic pain from it and numbness and tingling in my fingers. And she's like, I wish I knew that before because I wish they all knew that I was a violinist and I really wanted to play my violin. And since this has happened, it's been really hard for me to play my violin. And how how heavy that was to hear of I wish you knew who I was. I wish you knew I was more than my cancer. I wish you knew that I was a violinist, that that this is who I am and this is what I wish to strive for. Um, we talked about the Veterans History Project. Also, part of that, what we also did was the No Veteran Dies Alone project, in which you visit, again, veterans in the VA to make sure there's someone with them nearing their end of their life. And then narrative ethics. These are all just examples of how projects and things we can do to bring in more narration back into the medical system. So I think that's the end of my lecture. Really wanted to leave time for any questions and to talk about anything you all are doing at your hospital systems that we can learn from and implement here that we could all implement at our own respective hospitals.
Well, Sammy, that was an amazing lecture. I just love the history that you provided and just the ties between the early history of medicine and just the core values of palliative medicine now, and just the ideas for the stories, the pictures, and how we could implement that into our practice. So a lot of things I personally will reflect on and how I can bring this into practice. So just want to open up to anyone who has questions or thoughts, as Sammy said, how they're integrating these type of principles.
Thanks for a really great lecture, Sammy. I was just curious, have you ever come across parallel charting, really more for providers and trying to combat burnout? I don't know if that came up for you.
It did not, but now I'm interested. Parallel charting.
It's yeah, I don't pretend to be an expert in it, but just from what I've heard is that you essentially have the patient's, note that you wrote up on one side, and then you chart as you would have wanted to chart. Because a lot of times we hide things from the medical record or put things in a more tactful way, so that there's not, there's transparency, but we also know that a little bit too much honesty can be a little bit hard. And so you essentially chart as you would have wanted to chart the encounter. And it's just a way for clinicians to, I guess, process their own experience.
Yeah, I love that idea. I think having that direct thing of what I wrote to help really reflect on what you were hoping to or could write in that, I think is a really good way to keep you reflecting on the entire process. So I think that's one I want to try.
Another practical way of doing that on the short term, I just learned about this about 6 months ago myself after having Epic for 3 or 4 years. But there are certain sticky notes in Epic that you can write yourself your own notes or write down the patient story that does not become part of the chart. So I've been using that more and more often myself, really to capture a lot of that story that, again, you may not feel is important to go into the note, but you yourself as a provider want to remember. That's been very helpful for me.
Dr. Phillips, I love that. Well, it's funny, and I have one of those little sticky notes that I do the same, and I print my own list in the morning, and I feel bad because the team always prints lists for everybody. I'm always like, I don't know, I don't want your list, and it's not that I think my list is better, but I have my notes that I print for myself that are there just as a reminder, and always like have like parents' names there because I just want to have them as remember who I'm speaking to. But no, yeah, I love that idea.
The other thing I wanted to mention, Sammy, is I think you in pediatrics probably suffer from the same thing we do in neurology, where we get those rare diagnoses, Rett syndrome, those sort of things. And there is that excitement about the diagnosis. I just had it again last week where I think I'm coming up or saw a patient where I think I found another rare diagnosis, and somebody termed it well, in the neurology realm. We're always looking for those butterflies. You find the diagnosis. You're like that zoologist going out into the rainforest, and you collect your specimens. You collect the rare butterfly, you collect this, you collect that. And for your own personal narrative, it's something where you can say, yes, look at what I did. I studied hard. I was able to recognize this. This is great. This is wonderful. But you're absolutely right. We need to remember who that patient is and what this diagnosis truly means. So thank you for bringing that back into the picture as well.
Sammy, can you hear me?
I can.
Oh, okay. You can go first, whoever it was is gonna.
Oh, what a great lecture, Sammy. Just absolutely just wonderful. You know, two thoughts, and would just love to hear everybody's thoughts on this. You know, in my mind, this is how medicine should be taught. Narrative medicine should not even be a separate um, field of medicine. There shouldn't be a narrative medicine fellowship. This should be foundational to the medical school curriculum. So I just so appreciate you highlighting this, even though I think we all sort of do this, whether it's as intentional or not. But what are your thoughts around, you know, how this can be taken to other specialties? Because it's not enough for HPM, physicians to do this. By the time they get to, it's very important for us to do it. But what is your sense about what the culture of medicine is and the appetite for this kind of practice outside of HPM or anybody?
Yeah, at least throughout my medical education, that there has been more and more focus on trying to bring back humanistic and holistic care. And I think that we see it throughout, emerging more and more in specialties throughout. And I think the narrative medicine, in a way, if we do practice a lot of the themes of narrative medicine in HPM, and also there are a lot of things we don't practice.
Mhm.
It truly is that narrative medicine does pull in a lot of ideas of literature and evaluation of things back into more practice. So I think even for us in HPM, of truly doing more, I think, self-reflection, intentional things, whether it is, those weekly, monthly rounds with even ourselves of talking about patients, more narrative practice of reflection writing, parallel charting, which Rachel brought up. I think there are some things that we can adapt and bring into that push to the more holistic and humanistic care. I I think it's getting better with time and outside of just HPM.
Mhm.
How to continue that push? It's just so hard with, I think, those P's that I talked about of the 21st century, of this push of to productivity, this push to really algorithm-based medicine and no longer looking at our patients. So I think it's a battle that will continue.
Mhm.
And I think that there's been strides, but I would love to hear others' thoughts as well.
Always have lots of thoughts, but
Kara has lots of thoughts.
thank you so much, Sammy, for picking up this topic for a lecture. Um, when I presented that quote case, it was with a little bit of trepidation. We're so used to like presenting a specific case, but it just really struck me over the course of fellowship, how stories from our patients and being witness to that and giving space to that is so incredibly meaningful for, like you said, the healing process, or giving space to, this period of end of life, and just how hearing people's stories is so meaningful. Like that's part of it's like it's ingrained into our DNA, right? Like you've mentioned throughout your lecture how this is how we've passed down information, how we've passed on tradition, and how ingrained that is to so many different cultures, and how that's reflected in who we are as people. And to remember that in medicine, we're treating and caring for a person and not a diagnosis, and how important that is. So I'm just so glad that you reached out to me and you're like, hey, if you're not going to do it, then I would like to. So excellent job. I could keep talking, but I'll give the floor. I think Dr. Raffo has a question for you.
I just have a few comments. I mean, first of all, it is excellent. John Mulder would be proud. I mean, how many stories have we
Absolutely.
heard from him? I'm glad we got to hear a lot of them. Well, the other thing, just a story comment. I mean, we had a little bit of trouble with the audio earlier, but I did hear your initial story. I think some of the other people in the room can identify. My father's from Iraq, so I'm a first generation, and yeah, it was pretty much medicine or engineering for me. So I can identify with your story. Anyway, Dr. Van Alstine had a comment. We haven't been able to read all the comments, but he mentioned something about inviting the treatment team into family meetings. I mean, that would probably, I don't know how well that works in the hospital, but that might be a good way to help get others to do narrative. Medicine.
I first thank you, Kara, for your kind words. And also I love that shared connection we all have from if you're a first generation American or an immigrant. Like that is a shared experience of all of us. So I love that you're able, like we share that together.
Yeah, took us a whole year to figure it out, but yeah.
Yeah, and I think with Dr. Van Alstine, I hope that we can have scenarios in which we as HPM are having more of those narrative conversations with families to have our treatment teams involved with them. I think that'd be wonderful. I think even at times in which when we have residents on our pediatric HPM service, we often do a lot of times in peds, we have chronic patients, right? These kids of these children of medical complexity, where they're in the hospital for a while, and we do what we call investment visits, where we truly go in with no agenda, just to say hello and learn more about the family and learn more about the patient. So Dr. Hemker coined the term investment visits, and they really are. And even to have a treatment team around during an investment visit would be, I think, helpful for them to see if truly what we do is more than those acute scenarios of symptom management and goals of care, but really learning who families are and who patients are. Sorry, I don't want to take up too much time. Kristen has a case to present. Any last questions, concerns, complaints, comments? Well, thank you all so much for taking time to listen to me today, and then I will pause my video and step off and let Kristen take the stage. Or
Thank you again,
Dr. Fellows.